Welcome to Clinical Capsules from TRC Healthcare, your go-to podcast for fast, evidence-based insights. On this episode, clinical pharmacist Rachel Cole explores the latest developments in HIV pre-exposure prophylaxis, PrEP, with a spotlight on a new, long-acting injectable option, Lenacapavir, in an excerpt from our popular Pharmacy Essential Updates webinar series. TRC has been a trusted resource for healthcare professionals for over 40 years. And now we're bringing that expertise straight to your ears every second and fourth Tuesday in bite-sized, actionable episodes right here on Clinical Capsules. This podcast offers continuing education credit for pharmacists and pharmacy technicians. Please log in to your Pharmacist Letter or Pharmacy Technician's Letter account and look for the title of this podcast in the list of available CE courses. None of the speakers have anything to disclose. Let's dive in.
Our article gives us a quick overview of Lenacapavir or Yeztugo, the first twice-yearly subcutaneous injectable option for HIV PrEP. So let's brush up on our PrEP options and see how Lenacapavir fits in. Over 36,000 people are diagnosed with HIV in the U.S. each year. And with PrEP, the goal is to prevent HIV in high-risk patients by using antiretroviral meds long-term, to reduce their risk of developing HIV prior to exposure. We can emphasize how effective PrEP can be when patients are adherent. Oral and injectable PrEP reduces risk of HIV through sex by about 99% when taken as prescribed. Over the last several years, there's been an uptick in patients using PrEP. For instance, in 2022, about 36% of people who could benefit from PrEP were prescribed, and that's up from about 23% in 2019. But we still have an estimate of over 1 million people who could benefit from PrEP in the U.S., and additional resources are needed to address unmet needs to get more people on PrEP. So let's take a closer look at who's eligible for PrEP and how we can help identify potential candidates. And really, we should keep PrEP in mind in our discussions with all sexually active patients to help raise awareness and reduce stigma. HIV can affect anyone regardless of sexual orientation, race, ethnicity, gender, or age. And some examples of how we can do this in the pharmacy are watching for patients who report risk factors, maybe getting prescriptions for sexually transmitted infections, or patients who may be purchasing syringes or naloxone regularly, or generally promoting that your pharmacy provides PrEP. Just like how we let all of our patients know we offer immunizations or other patient care services, think of PrEP as another harm reduction service we can offer as pharmacists. And getting into the habit of discussing PrEP is key, since some patients may feel worried or embarrassed to ask about it. So this gives people an in to have further conversations. Plus, people at risk of HIV are often under-recognized or may not report that they're participating in high-risk behaviors or know their behaviors are risky, such as having unprotected sex with multiple partners, people who inject drugs, especially if they share needles, or those who've had a recent sexually transmitted infection, such as gonorrhea or chlamydia, during the past 6 months, since this shows they've had recent sexual activity that could result in HIV exposure. These are some groups who are particularly vulnerable to acquiring HIV and are likely to benefit from PrEP. So be ready to recommend or provide PrEP for these patients at increased risk, as well as any other patient who requests it, even if they don't report at-risk behavior. Again, realizing that not all patients will openly share information about their behaviors. But before starting PrEP, there are a few key things to verify. And one of the biggest ones is making sure that the patient is HIV negative, since using PrEP in an HIV-positive patient is linked to developing drug-resistant HIV. So document a negative HIV test before initiating therapy, ideally with an antigen antibody blood test. We want to stay away from rapid tests that only check for antibodies, including those that use oral fluid, because they are less sensitive for the detection of acute or recent infection than blood tests. Also ask about signs and symptoms of acute HIV infection, such as fever or night sweats, since there is a window period, or a time between HIV exposure and when a test can detect HIV in your body. Patients will also need other labs, such as tests for hepatitis or kidney function. So now let's talk about the medications that can be used to prevent HIV in these patients, including another recently approved injectable option, and some of the things to consider when determining which product may be most appropriate. There are currently 2 oral and 2 injectable options for PrEP that are approved for adults and adolescents weighing at least 35 kilograms or 77 pounds. So let's see how the oral meds stack up. Both Truvada and Descovy each contain 200 milligrams of emtricitabine, but their tenofovir component is different. Truvada contains 300 milligrams of tenofovir disoproxyl fumarate, while Descovy contains 25 milligrams of tenofovir alafenamide. Both of these are once-daily meds, and both of these will need kidney function monitoring with different creatinine clearance cutoffs for use. Both may also rarely decrease kidney function, but Descovy seems to have less of an impact than Truvada. A few other differences: Truvada decreases bone density, but doesn't seem to impact fractures, where Descovy may cause weight gain and increase triglycerides. And then we have injectable Cabotegravir, which contains 600 milligrams of extended-release Cabotegravir. It's administered by a healthcare provider into the gluteus or buttock via an intramuscular injection, once a month for 2 months, and then every 2 months thereafter. So this is a long-acting option where the orals are daily options. Also with Cabotegravir, regular monitoring of kidney function is not needed like it is with the orals. So Cabotegravir may be an option for patients with significant kidney disease, and Cabotegravir also does not seem to impact weight, cholesterol, or bone density. And then we have the recently approved injectable Lenacapavir, which contains 463.5 milligrams per 1.5 milliliter injection of extended-release Lenacapavir. It's administered by a healthcare provider into the abdomen or thigh via subcutaneous injections twice yearly, or every 6 months, or every 26 weeks. So this is another long-acting option. Also, like Cabotegravir, regular monitoring of kidney function is not needed like it is with the orals. So Lenacapavir may be another option for patients with significant kidney disease. Patients should get 2 subcutaneous or 927 milligrams total of Lenacapavir on day 1, plus 2 300 milligram Lenacapavir oral tablets daily on days 1 and 2, followed by 927 milligrams subcutaneously every 6 months. The initial and subsequent injections must be administered by a healthcare professional, and we should ensure the scheduled injections occur within 26 weeks, plus or minus 14 days of the patient's last injection. We can bridge with 300 milligrams of oral Lenacapavir once weekly if there is a delay of more than 14 days. But keep in mind that reinitiation with the injection tablet combo is required if there's a delay of more than 14 days without the oral bridge. There are many factors to consider when evaluating PrEP options. We've touched on how they're all highly effective if taken as prescribed, and then kidney function, but we also want to consider the patient population we're treating and if patients are pregnant or breastfeeding. Cost may also play a role, as well as interactions may impact which option we recommend. Then we use shared decision-making with PrEP candidates to identify a regimen that will work best for them. So let's review some other med considerations. Truvada and Apretude are recommended PrEP options regardless of high-risk behaviors. Descovy is only approved as PrEP for men and transgender women who have sex with men. We can go ahead and suggest Truvada first for most patients, since it's effective, can be used regardless of high-risk behavior, and it's the least expensive option. It also has the most evidence for use during pregnancy and breastfeeding, and for people who inject drugs. We can think of Descovy instead of PrEP for patients with osteoporosis or moderate kidney impairment, since it's less likely to decrease bone mineral density or kidney function compared to Truvada. We can consider long-acting injectable cabotegravir or lenacapavir for patients who have severe kidney impairment, have difficulty adhering to oral PrEP, or prefer getting an injection every 2 or every 6 months over taking a daily pill. And regardless of which med is used for PrEP, we as pharmacists and techs play a key role in helping ensure therapy is safe. One way we can do this is by making sure med profiles are updated and watching for drug interactions. For example, tenofovir disoproxil fumarate in Truvada interacts with some Hep C meds such as Epclusa and Harvoni, leading to increased tenofovir levels and the potential for increased kidney injury and other side effects. Cabotegravir or the tenofovir alafenamide in Descovy interact with certain meds such as phenytoin or rifampin. These meds can significantly decrease cabotegravir concentrations. If patients need to stay on these medications, usually recommend Truvada instead. Also advise patients on cabotegravir or Descovy to avoid St. John's wort. Now, our newest PrEP option, lenacapavir or Yeztugo, is a substrate of CYP3A and P-glycoprotein or PGP, and moderately inhibits CYP3A and PGP. Consider another PrEP option for patients already on a strong inducer, such as carbamazepine or phenobarbital. And be mindful that if a patient already on lenacapavir starts a strong or moderate inducer, supplemental oral and/or injectable PrEP doses may be needed. Lenacapavir is administered subcutaneously into the abdomen or thigh, and since it takes 2 injections to administer the full dose, make sure that second injection site is at least 4 inches from the first and at least 2 inches from the navel. Lenacapavir for PrEP can be stored at room temperature and keep the vials in the original carton to protect from light. To help manage any discomfort from the injections, cold packs can be applied to the sites before and after injection, or use an oral analgesic if clinically appropriate. And keep in mind, a drug depot collects under the skin at the sites, so it's common for patients to feel a bump or a nodule just under the skin. Overall, all 4 PrEP regimens are well tolerated, and we can emphasize this and help set patients up for success. With the 2 oral meds, caution patients about a startup syndrome, which includes a headache, nausea, diarrhea, and improves with time. Usually it lasts less than a month. Educate that GI upset usually lasts less than a month, and to take it with food to limit initial nausea. We don't see this startup syndrome with cabotegravir or lenacapavir. The main concern with the injectable options is injection site reactions, which includes pain, tenderness, local swelling, and these are usually manageable and temporary. We can also help break down cost barriers so that price doesn't get in the way of HIV prevention. Point out that most patients can get PrEP with no copay under the Affordable Care Act, and manufacturers often have med assistant programs. Also check for state programs, and there are multiple patient assistant programs found on hiv.gov. In addition to counseling on what side effects to expect and how they're usually temporary, and helping patients afford their PrEP, there are other ways we can also encourage med adherence. Recommend technology, such as using smartphone apps, or help set up refill reminders or offer prescription delivery. We should also take the opportunity to emphasize other safe practices, including condoms, and remind patients PrEP only protects against HIV, not other sexually transmitted infections. We can also remind patients to follow up at least every 3 months for oral PrEP, and for cabotegravir, advise follow up 1 month after the initial injection for the second injection, and then recommend follow up every 2 months for cabotegravir. Patients on the lenacapavir injection for PrEP should follow up every 6 months for their injections and HIV screening. But follow-up can be more frequent and as needed, in addition to check-ins via text or calls in between in-person visits. Follow-up is important for many reasons, including repeat HIV testing, refilling prescriptions, and screening for other STIs. Check out our online resources, our new drug graphic for lenacapavir or Yeztugo for PrEP, and the updated HIV pre-exposure prophylaxis checklist for more details on all HIV PrEP options.
We hope you enjoyed and gained practical insights from listening to this episode. Now that you've listened, pharmacists and pharmacy technicians can receive CE credit. Just log into your pharmacist letter or pharmacy technician's letter account and look for the title of this podcast in the list of available CE courses. We've linked the resources we mentioned and more on today's topic right in the show notes. Those links will take you straight to our websites, where you'll find even more concise, evidence-based charts, articles, and tools. If you're not yet a subscriber, now's the time. Sign up today to stay ahead with trusted, unbiased insights and continuing education. And as a listener, you can save 10% on a new or upgraded subscription with code CC1025 at checkout. Also, be sure to explore our other TRC content, podcasts like Medication Talk and Rumor vs. Truth, plus our full Pharmacy Essential Updates webinar series for deeper dives. Thanks for listening. Stay sharp, stay current, and we'll catch you next time on Clinical Capsules.